Good morning. I'm Theo Anderson, an Assistant Detention Trustee with the Office of the Federal Detention Trustee, United States Department of Justice, Washington, D.C. The following Suicide Prevention and Program Monitoring Training presentation is a collaborated effort between the Office of the Federal Detention Trustee, United States Marshal Service, the Federal Bureau of Prisons, and the National Institute of Corrections. It is my distinct honor and pleasure to introduce to you the presenters for this training. From the Federal Bureau of Prisons, we have Dr. Allison Lukefeld, PhD. Dr. Lukefeld serves as Clinical Treatment Coordinator in the Office of Psychology Services for the Federal Bureau of Prisons. Also presenting will be Dr. Jamie Brower. Dr. Brower is American Board Certified in Police and Public Safety Psychology and serves as a subject matter expert for the offices of Nicoletti Flatter Associates in Lakewood, Colorado, where she serves as Clinical Director and Training Coordinator. I would also like to thank Commander Anita Pollard of the National Institute of Corrections. Commander Pollard serves as a Corrections Health Manager for the National Institutes of Corrections. During the course of the next hour, the training presentation will focus on increasing suicide awareness prevention and implementing effective suicide prevention programs. Without further ado, I present to you Drs. Lukefeld and Brower.
Thank you, Theo. This is Dr. Allison Lukefeld, and today Dr. Brower and I will be going back and forth to share our thoughts on the topic of jail suicide. We're honored to be presenting on behalf of the marshals on this topic of jail suicide. We have several objectives today. The first of which is to review the problem of jail suicide, and we'll be talking about why it is such a difficult problem to address and some of the characteristics of the problem as it has existed over time. We'll also be describing suicide risk as it exists, and specifically we'll be focusing on ways that staff in jail can identify suicide risk in inmates. Finally, we'll discuss intervention procedures and best practices to address this problem and reduce it. The problem of jail suicide has been an enduring problem. It's one that has existed over time, even though it has reduced considerably. And today we're going to talk about why we should spend resources and time addressing this problem. Some of the obvious reasons include saving lives and helping people, but there are other issues as well, such as reducing the daily stress that correction officers face, and reducing the amount of resources spent when suicides do occur.
Another goal of suicide prevention is also trying to think smarter instead of working harder when it comes to managing inmates with regards to this issue. It's not always just the suicide prevention, but it's also in reducing the amount of work.
So how do jails compare in terms of the numbers of inmate suicides? On this chart, you'll see first the issue of suicides in the community in the United States. And the overall number in light blue is 11 suicides per 100,000 in the United States. Men have a higher rate of suicide at 18 per 100,000, and women have a lower rate at 4 per 100,000. In state prisons, we don't have separate data for men and women, but we know that the overall suicide rate is 14 per 100,000. In federal prisons, we know that there are very few female suicides, and so in fact the overall rate and the male rate are the same, and they are 10 per 100,000. In jails, the suicide rate per 100,000 is 36, which is much higher than state prisons, federal prisons, or the United States at large. And jails have historically had the highest suicide rates among these groups. Here you see jail suicide rates overall. In 1986, NIC conducted a study which showed that there were 107 inmate suicides per 100,000 in jails across the U.S. By 2002, BJS conducted a study that showed that jail suicide rates had dropped to 47. And then you see the most current data that we have from 2006, which shows inmate jail suicides at 36 per 100,000. So even though these rates are higher than in other groups, they've certainly dropped over time. The jail suicides have decreased. It's dropped nearly threefold over the last 20 years. And what we know is that as attention to this problem, training, national standards, and litigation have increased, jail suicides have decreased. Although not as dramatic, similar drops can be observed in the prison suicide rate. So what makes jails risky? Specifically, what makes them more risky than the community settings and prison settings that we talked about earlier? Jail environments are conducive to suicidal behaviors. Jail environments diminish personal control. Often, an inmate's old coping mechanisms may not work while they're incarcerated. Those coping mechanisms may have been healthy or not healthy, but they're no longer available in the controlled setting of a jail. Additionally, jails separate inmates from social support networks. Those networks may include family, friends, or mental health professionals that they relied on in the community to function. Jails provide isolation and privacy, and this is really key to the issue of suicide, and that most suicides happen in a private setting. We know in the community, individuals who are not married are more likely to commit suicide, and if an inmate is provided a single cell, he or she is more likely to commit suicide.
Another thing that's important about why jails are risky include the fact that many of your folks are brought in a state of crisis. They are oftentimes pretty upset and worked up, and so you also have some impulsivity there as well that complicates the intake.
And depending on the jail may or may not have mental health resources, and those resources may or may not be able to match the level of mental health care that the inmate was receiving outside in the community. So all of that said, the problem of jail suicide is not only about jails. It's also about inmates. And jails tend to be repositories for high-risk groups. Inmates actually import risk into the jail setting. So jails hold statistically high-risk groups for suicide. Young men, the mentally ill, substance abusers, and individuals who have made previous suicide attempts. As a group, inmates have higher suicide rates than their community counterparts, regardless of their incarceration status. And many people who are incarcerated show increased levels of suicide thought across the course of their lives, again, regardless of whether they're incarcerated. So in a jail, what we've got is a perfect storm. A vulnerable population, a risky setting, and all of the stressors that come along with initial incarceration, to include shame of having been incarcerated, fear of the unknown, possibly fear of other inmates, and relationship stressors within the support system. So having described the problem, we're going to talk for a minute about the challenges of prevention. Smaller jails have higher suicide rates. In fact, they're 5 times higher in jails holding less than 50 inmates. And these suicides account for 14% of jail suicides. So in terms of addressing the problem, that means that while it's important to focus on large jail systems, it's also necessary to focus on a large number of small jail systems, which is a larger challenge. NIC has done studies that tell us that many jails do not provide suicide prevention training, or if they do, they don't provide it annually. Most jails have a suicide prevention policy, but many of those policies are not comprehensive. So in sum, what we see is that there are a lot of cultural issues, resource issues, and knowledge issues to be addressed in regard to jail suicide prevention. All right, so we've described the problem of jail suicide, and now we're going to spend some time discussing suicide risk and describing the characteristics of suicide risk. What we know is that there is no 100% test for what suicide risk is, and there's no definite way to know who is at risk for suicide at any given moment. But there are a lot of things that we would like for staff to know about what puts certain offenders at risk so that they know what to look for. These are risk factors and warning signs. So what is a risk factor? A risk factor is a characteristic of a large sample of people who have committed suicide that appears to be statistically more common than would be expected. We're talking about statistically relevant characteristics. First, we'll talk about general risk factors. That means that these risk factors are relevant for inmates, but they're also relevant for your coworkers, your family, your friends, and yourself. These are risk factors for everyone in the United States. In order to help you remember some of these risk factors, we're presenting a mnemonic device, and the device is sad person. So if you can remember the phrase sad person, the first letter of each of these words will spell out that phrase. First is sex. We know that 73% of U.S. suicides are committed by white males. 60% of those suicides are by gunshot. Second is age. 15 to 24-year-old males are at the highest risk for suicide. For that group, suicide is the third leading cause of death. Individuals over the age of 65 are also at significant risk. So among age, the very young and the very old are at higher risk. Depression is a risk factor for suicide. 30 to 40% of people who die by suicide are diagnosed with depression. P stands for previous suicide attempts, and approximately 15% of individuals who have attempted suicide will eventually complete suicide. Individuals who have made a life-threatening attempt are at greater risk. A recent attempt followed by remorse that the attempt was not successful is a warning sign. So certainly if someone attempts suicide and then says, gosh, I messed up, I really wish I would have died, that is a very strong warning sign, not just a risk factor. Ethanol abuse is a risk factor, and we know that alcohol has been recently consumed by 15 to 25% of those who complete suicide, and 55% of individuals who attempt suicide. Alcoholics are an especially high-risk group in that 15% of them die by suicide. R in the mnemonic stands for rational thought loss. This is psychosis, and individuals with schizophrenia and depression, or depression with psychotic features, are at much greater risk for suicide. S stands for social support lacking. We know that individuals who have limited social support, or importantly have recently lost social support, such as having gone through a divorce or lost a family member, are at greater risk for suicide. N stands for no spouse. Separated, divorced, widowed, and single individuals are at greater risk. And finally, S is for sickness. Individuals with chronic health problems are at greater risk for suicide, especially if those chronic health problems result in pain or a lot of physical discomfort. Now I'm going to talk about some risk factors that are specific to inmates. Inmates who are in the first week of their incarceration are at special risk, and we talked about that perfect storm and the stress of initial incarceration. Pre-trial inmates who have not yet gone to trial or been sentenced, who don't know kind of what will happen to them, they have a lot of questions, are at greater risk. Mentally ill inmates who may be psychotic or depressed are at greater risk. Single-celled inmates are at greater risk, and this is a really important risk factor because it's one that jails can exercise a lot of control over. If you believe an inmate to have some risk factors, one of the ones that's easily controlled is single-celling, and we suggest double-celling all inmates who are at risk for suicide. And finally, sex offender inmates we see having a greater risk for suicide, maybe because of the embarrassment of having been caught and arrested, maybe because of the protective custody issues they may face when they're in custody. So we talked about risk factors, and some of the pros of looking at risk factors are that they help us identify risk, and they can help staff to be more aware of who is at risk. Some of the difficulties associated with using risk factors to identify inmates for suicide is that even though they're statistically predictive, they describe lots of people. When we talk about men being at risk, clearly there are a lot of men, and we know that not all men are at risk for suicide. So risk factors tend to be overly inclusive, and because of that, we also look at warning signs in order to help us identify who may be at risk for suicide. So what is a warning sign? Warning signs are different than risk factors because they're behaviors that a person exhibits rather than a group characteristic. It's a behavior exhibited by someone who is considering suicide. So here are some of the warning signs that you would see in general for anyone who might be considering suicide. Again, this could apply to coworkers equally as it would to inmates. Withdrawing from family and friends, pulling back, isolating, not engaging with people in the way that they used to. Suspiciousness, maybe wanting to hide something, not being open about the ways they're feeling or about the problems that they're encountering. Saying goodbye. And we see this in a lot of ways. It can be as literal as telling somebody, hey, it's been great to know you, but you might not see me around anymore. And it can also mean preparing wills or writing letters or making amends. So saying goodbye can take a lot of different kinds of behavioral.
Even after sentencing, sometimes we've got folks who will have a particularly poor sentencing outcome, and they will say things like, I'm going home, I get to go home. So that's another form of saying goodbye.
Giving away possessions is one that we see, I suppose it could happen in the community, but we see it in correctional settings a lot, where an inmate gives away a watch or best pair of tennis shoes, things like that, maybe settling debts, that kind of thing, once they've made a decision to attempt suicide. And then finally, symptoms of depression, a sad mood, loss of interest in things that used to be fun and engaging, fatigue, appetite disturbance, either eating too much or not enough, and disturbed sleep, which can be sleeping too much or not sleeping enough.
And you'll want to look at these warning signs specifically as deviations from the inmate's baseline behavior. So the baseline behavior is what they typically engage in on a day-to-day in a day-to-day way or a day-to-day manner. And when you see something change either in mood, interest, giving things away, suspiciousness or paranoia, then we have a deviation. And with the inmate population, you do have the ability to watch and pay attention and identify some of these deviations early.
All right, so now we'll talk about some warning signs that are specific to inmates. One of the most important ones for jails is a suicide statement made at the time of arrest. And it's very important to get this information from the arresting officer and to know if a suicidal statement was made. In addition to that, suicidal statements might be made later on through letters, through phone calls, and all of those are a very important warning sign to note and to consider that person at risk. Another one is rehearsal of behaviors, rehearsal behaviors for suicide. And we see this not infrequently. Correctional settings are unique in that there's so much opportunity for observation. And in reconstructions that I've been a part of, we often realize that behaviors that seemed odd at the time and were observed were actually rehearsal for suicide. So if a noose is found in an inmate's belongings, they may well have been preparing and rehearsing for a suicide attempt. If we see an inmate putting a bag over his or her head, those kinds of things are rehearsal behaviors. Similarly, an inmate may cut their wrists, and it may not be a life-threatening cut, but it may be a rehearsal for an eventual suicide attempt that is life-threatening. Trying to obtain a single cell can be a warning sign, especially when it's paired with other high-risk behaviors. So most people prefer to commit suicide in private, and having a single cell is the first step to getting that privacy to be able to carry out a suicide attempt. And finally, hoarding medication. Hopefully, we're doing good checks on the kind of property that inmates have in their lockers and in their possession, and making sure that they're not hoarding medication that could lead to an overdose. All right, we're going to talk for a few minutes about myths. And just like you probably don't want to kiss a frog, there are some other myths that you might not want to endorse in your practice in a jail, because the outcome probably will lead you down the wrong road. Okay. The first myth is, if a person decides to commit suicide, he or she will find a way to do it regardless of what we do. And the belief that goes behind that myth is that decisions are final. Once somebody makes up their mind, there's nothing we can do about it. The facts are different. The facts are that suicidal impulses are often brief. So somebody might want to commit suicide in a moment, but they might have other feelings about it too. And later on, they might be thinking about it differently. It's important to help them survive through that moment so that the other thoughts and feelings they have can be worked with, and they can make a different decision.
Sometimes just thinking about suicide can be a coping skill, which can actually relax them and create some calmness, just thinking about alleviating what's bothering them. So sometimes it's purely used as a coper.
Another one of the facts about this myth is that most suicidal people have mixed feelings about dying. Most suicidal people feel very strongly in both directions. They feel strongly that they want the pain and the discomfort to end, and that they don't want to live through what they see as a very unhappy future. But they often also feel very strongly about the good parts of their life. They feel strongly that they might want to see their children grow up, or that they might want to get through their incarceration and get out and re-engage with their families. And so the decisions usually are not final, because there's usually strong evidence on both sides of the decision-making process. And finally, the methods available to commit suicide can influence the occurrence and the outcome of suicidal acts. So we know that if we're able to keep somebody safe for a short time when they're feeling suicidal, often that period will pass and they'll have a different outcome. Another myth is that asking a person about suicide might give them the idea. Sometimes we hear folks say, "Oh, I don't want to ask about suicide. That might give them the idea, and then it will be my fault that they did it. So I didn't bring that up." And the facts are quite different. Asking about suicidal thoughts will not cause suicide. In fact, showing concern will likely assist the inmate. Often, it's important. The inmate will say, "Oh gosh, I didn't want to say anything, but here's what I was really thinking." And if they're not feeling suicidal, often they're very frank about that too. "Oh no, I would never do that because of a spiritual belief or because of my family." So open dialogue will almost always assist in identifying problems and attaining help if suicidality is on the table for that person. Okay. The third myth we're going to talk about is that inmates who threaten to kill themselves don't really want to die. Sometimes we tend to think that the inmates who make multiple attempts or who engage in multiple self-harm behavior don't have any desire to die, and in fact, they're the ones that we don't need to worry about or think about. They're not the problem, they're just taking up time. It's kind of the storyline that goes along with this. And in fact, that's not the case. Individuals who threaten suicide are actually at much higher risk for an actual completed suicide.
Sometimes, the more frequently that they speak about it, they may actually be desensitizing themselves to the idea of engaging in an act of suicide.
And suicidal intent can change quickly. So we may see that a particular individual is not suicidal at one point, and so we say, well, we assessed them, or the doc looked at them, or we know they're not suicidal because last week mental health came down and checked them out. But in fact, suicidal thoughts and intention change quickly, and so we know we need to pay attention to that every time it comes up. Just because someone wasn't suicidal last week doesn't reflect on where they may be this week. Another problem that occurs in jails not infrequently is that the lethality of self-harm acts can be easily misjudged. Most of us imagine that if we were to shoot ourselves, we know the outcome would be death. But inmates have a lot of misinformation about hanging, and hanging tends to be the most common method used in a correctional setting. They often misjudge how long it will take for them to pass out when they place a ligature around their neck, and in fact, accidental death can occur.
The other thing, too, is that a lot of times folks who are in charge can become very disheartened with the repeated attempts or repeated threats to kill themselves, and at times may say, well, I'm not going to send them to mental health because this is a game. They're just looking for a change in venue. And really what we tell people is, look, if you do that and you say, no, I'm not taking you, then you place the inmate in a situation where they have to save face. And in order to save face, if you don't take them, they almost are forced to engage in an act of attempted suicide, or you'll see them escalate so that they can prove to you how distressed they are. So always take them.
All right, the final myth we're going to talk about is that if we ask about suicide and the inmate denies it, we've done our part. They said they weren't going to do it. And this is an interesting myth because very rarely do we take inmates at face value with the self-report information they give us on all kinds of topics. If they said, well, I didn't commit that crime, we wouldn't necessarily just drop charges. And if they said, well, I didn't steal those onions out of commissary, we wouldn't say, okay, it must not have been you. But when an inmate says that they're not going to commit suicide, we're often too quick to take them at their word, when in fact we need to take other data into account. So the facts here are that there are many ways that individuals may communicate suicidal intent, and their words may be one of those ways, but they may not be. They may show behavioral signs, or they may be calling home to talk about their depression or their feelings or their intent to die. There are a lot of ways that they come out, and face-to-face with a mental health provider may not be the main way. Additionally, if individuals could always know and communicate their own risk, there really wouldn't be any risk. The fact is that a lot of folks aren't very good at knowing themselves and knowing how upset they are or how upset they may become if things don't go their way. And so asking them to explain that to us is not something that they're going to be able to do.
And you're also dealing with folks who have major mental health conditions. Some of them anyway will have a major mental health condition and are relatively impulsive. So those combined really increase risk and perhaps a lack of an opportunity to communicate.
I think the take-home message about this myth is that mental health professionals are trained to examine all the risk factors and make informed recommendations. And so if you see warning signs or a lot of risk factors for an inmate, even if they say they're not going to commit suicide, it's worth having them assessed so that somebody who's really trained to make that assessment can do it. So now we'll talk about a few cases. The first case is the case of an inmate who might be considered to be manipulative. That's a word that we don't like to use because it conveys some wrong messages, but I know it's one that's frequently used, so it shows up here. And you see some of the characteristics on the slide of this inmate. He exhibited self-harm behavior and disruptive behavior. He often met his needs through threats and demands of staff. And he claimed inconsistent mental health symptoms, so it was difficult to know exactly what the problem was. This was a pre-trial inmate, in a detention center. He was young and an American Indian, so those are high-risk groups. He provided inconsistent personal history regarding all kinds of things, from his country of birth to his academic successes or failures to his mental health problems. And upon intake, he reported a prior suicide attempt that had happened in the last year, and during that attempt he cut his wrist superficially. He minimized this attempt. He said, it really wasn't a big deal. I didn't really cut. I wasn't thinking. I would never do anything like that again. Nonetheless, he was given a suicide risk assessment because the attempt had happened recently, and he denied any current suicidal ideation. While he was in custody, which was for a period of about 2 months, he frequently engaged in disruptive behavior, and you've probably seen these kinds of behaviors before. Things like not allowing the food slot to be closed, refusing to return to his cell following recreation, being belligerent and threatening towards staff, breaking a cell window. At one point, he made superficial cuts to his wrist with a fork, and he made some nooses that he showed to staff over time, making threats about what he might do. So, on the day of his death, he had 2 contacts with mental health staff, and he appeared agitated. He was experiencing a change in his correctional status. He was going to be moved to another facility, and he was unhappy, but he wasn't suicidal. He was assessed and found that there was no reason to believe that he was suicidal. He had inmates and staff near his cell all day long who heard him not upset, but sleeping or talking or those kinds of things, fairly regular behavior. But then in the evening he was found leaning against a ligature that was pulled tight by the weight of his body. He didn't leave a note. And so for this inmate, it would appear that although he didn't leave a note, we don't know exactly what happened. He had a long pattern of trying to get what he wanted or to make demands from staff by engaging in behaviors that were sometimes harmful to himself and sometimes to others. It would appear there's a good chance that he didn't intend to commit suicide but had an accidental death. So the lessons learned here are that first of all, self-harm behavior does not reduce or rule out suicide risk. This was not an inmate that we should have considered less risky because he was engaging in these kinds of behaviors. In fact, those behaviors increased his risk. And so it's important to take every act of self-harm seriously. Even though, in this case, the inmate had minimized a prior attempt, saying that it wasn't serious, that he didn't mean it, he wouldn't do that kind of thing again. And also, high-risk behavior can lead to accidental death. So it's very important when we can identify an inmate as high risk to reduce or eliminate tie-off points, especially in cells where high-risk inmates are housed, and whenever possible to double cell high-risk inmates with one another. Here's another case of an inmate who claimed that he was not suicidal. At the time of arrest, this detainee attempted suicide by stabbing his thigh near his femoral artery. It required hospitalization for the first 3 weeks of his detention, so it was a quite serious attempt. Upon transfer to the jail, during the mental health portion of the intake screening, the detainee gave positive responses to 6 of the mental health screening questions, including history of mental illness, depression, medication, having thoughts of hurting himself, and having made a prior suicide attempt. Based on this information, he was placed in medical observation in the jail health unit. The following day, a comprehensive mental health evaluation, the subject discussed his previous suicide attempt and indicated that he regretted stabbing himself. He said he did not die for a reason and that this kind of thing would never happen again. He also stated he was just feeling hopeless knowing he was about to be arrested. He declined further mental health counseling and said he didn't want medication. During a subsequent evaluation, he stated about his prior suicide attempt that he had total regret and that it was a stupid and very dumb thing to do. He said he had every intention of facing the future. His mood was good and he denied thoughts of hurting himself or suicide ideation. He was released to the general population to a 4-man cell and placed on medication. 2 weeks later, he received a medical evaluation by a medical doctor with no negative indications. And after that, he received another psychiatric evaluation. He again denied any thoughts of self-harm or depression, and he appeared stable. At 6:55 a.m., 45 days later, the detainee committed suicide. Although housed with 3 other inmates, he waited until they were all asleep, and the housing unit officer passed his cell during rounds. Then he cut his artery in his neck and he cut his throat by using a properly issued disposable razor. He wrapped his throat with extra clothing so that the blood pool would be less noticeable. He left a 4-page suicide note in which he stated that his medication was not working, but that he could not inform medical staff for fear of being locked in solitary confinement. Interviews with other detainees indicated that the subject frequently cried in the shower, especially after phone calls. He seemed depressed and that he slept a lot. In the prior month, he missed his pill line for his medication 8 times, but his failure to show up was sporadic and not consecutive. The review indicated that the training and responsive staff were all adequate. To improve their suicide prevention program, the jail posted information in housing units to educate inmates on the signs and symptoms of suicide ideation, and they created a watch list for staff so that staff would know which detainees were considered to be at high risk. So, the lessons learned for this case are that suicidal inmates may deny symptoms. And again, we don't trust inmate self-report on lots of different issues, and it's important not to take this at face value. We need to assess behavioral markers in addition to self-report and utilize multiple sources of information, including the reports of other inmates.
This is also a great place for that deviation from their baseline behavior. If you notice that they're not showing up for medications, if you notice that there's something changing about behavior, it can change relatively quickly. Many mental health conditions can cycle frequently, and so they may go quite a while feeling well, and then within a period of weeks be faced with another bout of depression.
Okay, also, it's important to remember that inmates may actively hide suicidal plans. So, addressing inmate fears about suicide watch, and this is something that we tend to see in jails more than in prisons, where inmates are very fearful about how they'll be treated on suicide watch, whether it will be embarrassing, what that means. And I think that has potentially something to do with inmates being a little bit naive when they're in a jail. They're new to the setting and they don't know what it means. So they're nervous about their status and that they might be uncomfortable there. It's also important to identify high-risk inmates, and a hot list is a great way to do that so that staff know who's at risk and can be especially mindful about those inmates in case they should observe warning signs. And finally, referring whenever warning signs are observed. All right, next we're going to talk about best practices for prevention. So these are things we hope you'll be able to put to use in your institutions and facilities. One of the most important things is having a suicide prevention program for each institution. And NIC recommends that each suicide prevention program has certain qualities, and I'm going to talk about those briefly, and then throughout the rest of the presentation, I'll talk about the most relevant one for jails. First of all, a training program for staff. It's important that staff are trained initially, and it's important that they receive annual refresher training on the topic of suicide prevention to ensure that their skills and knowledge stay current and up to date, and that they remember what kinds of things it's important to look for in the inmate population. Second of all, a plan for identification, referral, and evaluation. That means determining which inmates are at risk, referring them, and assessing them. Next is housing, which is looking at how inmates at risk for suicide will be housed and cared for. Observation and a treatment plan, which means observing them to ensure that a suicidal act doesn't occur, and then following through with the treatment plan to make sure that mental health needs are addressed. Intervention, notification and reporting, and critical stress debriefing, and mortality morbidity reviews. So that means taking care of staff if an incident should occur, and looking at the system to determine what kinds of things might change or could be improved upon after an incident so that we can prevent future suicides. All right, so a written suicide prevention policy. What we know from NIC is that many jails don't have written prevention policies, and those who do may not have a comprehensive plan. So that's really important. Written policies help staff to work together, and they help to clarify priorities. I'm going to talk briefly about a legal case that demonstrates the importance of a written policy. This is Buffington versus Baltimore County. The decedent, with a long history of depression and substance abuse, was arrested and placed under protective custody after police received a telephone call from the family stating that he had departed the home with several rifles and handguns. A suicide note was left and subsequently given to the police. At booking, an officer asked the decedent what he was going to do with all those guns, to which he replied, "I was going to shoot myself." As per departmental policy, the decedent was handcuffed to the bar at the booking desk for processing. An unwritten policy, of which not all officers were aware, was that suicidal inmates were not to be placed in the cell block. As the arresting officers were completing paperwork on an emergency commitment of the decedent to a psychiatric hospital, a cell block officer placed him in a cell block in isolation. Within 1 hour, the decedent was found hanging from the cell bars by his trousers. He was immediately cut down and CPR was initiated, but the decedent later died at the hospital. So what we can take from this is that in the absence of a written policy, officers weren't clear about exactly what to do. And even though they had an unwritten policy, not everybody knew what it was. And we had an inmate who was clearly suicidal who got through the cracks, so to speak. This is some data from the Bureau of Prisons, and it looked at suicide rates before and after implementation of a national suicide prevention program. And what you see on the far left, the black bar, is data from between 1970 and 1981, where the Bureau of Prisons was experiencing 35 inmate suicides per 100,000. That's the 5-year period that occurred before the implementation of a national suicide prevention program. At the end of 1981, the Bureau implemented that program, and what you see is an immediate drop for the next 5 years in the number of suicides, and immediate drop the next 5 years for the number of inmate suicides. And over time, the inmate suicide rate for the Bureau continues to rise and fall slightly, but a national policy where everybody understood what was expected and that suicide prevention was a priority made a huge difference for this agency in terms of the occurrence of inmate suicide. Along those lines, having a culture of prevention is one of the most important things a facility can have in order to prevent inmate suicide. It's important that all staff know what the warning signs for suicide are and that they feel empowered to make referrals and they know who to make those referrals to. Staff should communicate effectively about their concerns so that they know who to talk to. They have some language that some common language from training about what concerns are and how to talk about those. And importantly, supervisors should model prevention attitudes and behaviors. It's the old saying, if you think you can't, you're right. It's definitely true in this case. If you don't believe you can prevent suicide, you won't be effective in doing it.
And most prevention strategies, bottom line, again, help with the thinking smarter instead of working harder. You end up preventing inmate violence to themselves, but also potentially preventing some danger to staff, along with additional paperwork and other reviews. So the idea behind it is really, if we can prevent it, then we don't have to deal with the cleanup and the aftermath of it. So really having that attitude shift is important.
Okay, suicide prevention is a process. This is one of the things we know. It's not an event. It's something that facilities have to do all day, every day, and it has to be interwoven into the regular routine of managing inmates. So we know that it should start at the point of intake screening, but it needs to continue, especially at high-risk periods. For inmates, those often have to do with sentencing, with family relationship issues as they may come up, or internal stressors like feeling threatened. Suicide prevention also hinges on the value of staff referral. This should be happening every day as staff observe inmates in their setting and look for warning signs and risk factors. All right, in talking about best practices, one of the most important things facilities can do is to use wise correctional techniques. And at the top of that list is double celling at-risk inmates. Double celling reduces risk for suicide overall, and that's because it reduces isolation. Inmates aren't as likely to feel lonely or to isolate themselves. It reduces privacy, which is something that many people feel they need in order to engage in self-harm or commit suicide. And it produces a rescue opportunity so that even if an inmate should attempt suicide with another inmate in the cell, it's very likely that that other inmate will call for help. It's a great strategy to use with high-risk inmates. Additionally, it's important to place at-risk inmates in higher visibility cells. It's worth considering placing them at the front of the range so that anyone who enters that range will walk by. And then, importantly, reducing or eliminating the presence of tie-off points in the cell for high-risk inmates. It's ideal to do it for all inmates, but to really look at the cells where we know high-risk inmates are and to pay special attention there. All right, here's another legal case. In this case, the decedent was incarcerated in the county jail in January of 1989. During the intake assessment, he reported a prior history of IV drug use, a suicide attempt, a family history of suicide, and substance abuse, and the recent death of his grandfather. The decedent was currently suffering from hepatitis. During the 7 months of confinement, he engaged in aggressive, combative, and self-destructive behavior, resulting in both disciplinary confinement and observation under suicide watch. In August, the decedent engaged in self-destructive behavior, was transported to the local hospital for treatment of injuries, and was subsequently returned to the jail and placed on suicide watch. Less than 2 days later, he was found hanging from a ceiling by a bed sheet. The medical examiner later determined the decedent had been dead for approximately 5 to 7 hours prior to being found. So this is a case that emphasizes the importance of rounds and observing warning signs. This particular inmate had a lot of warning signs. The repeated engaging in self-harm behaviors, the history, the previous attempts, and doing regular rounds and placing that inmate in a high visibility cell, ideally with another inmate, are the kinds of things, the kinds of best practices that we would emphasize. Emergency response is one of the very important duties that law enforcement have, especially in regard to suicide attempts. So it's important that staff need to undertake an emergency response. Initiate life-saving efforts, and provide emergency medical assistance. And in training, it's easy to think, of course, we'll initiate an emergency response. What could go wrong? But in fact, there are all kinds of things that can go wrong with an emergency response. It's not something that happens every day. By its nature, it's an emergency. And so staff really need to be prepared. Emergency response is a key component of suicide prevention training. Here are some of the things that can go wrong. Staff may prematurely decide that the offender has died and then not offer that emergency response. Sometimes staff don't promptly initiate life-saving measures. Medical equipment may not function, or it may not function in the correctional environment. For example, the stretcher is too wide to fit down the range. Key medical equipment isn't brought to the scene, so it's not present when it's needed. Suicide cut-down tools may be present but ineffective, and that can easily happen if they're used for purposes other than suicide emergencies. Staff may not carry appropriate protective gear, and if staff don't have gloves or a one-way mask, they may be very hesitant to engage in life-saving measures. Staff don't know where the AED is located or how to use it. If your facility has one of those, it's important that staff are trained and they know exactly where to find it in case of an emergency. Many suicide emergencies involve a neck injury, and backboards often aren't used. Staff may open cell doors to respond before assistance arrives. It's important that staff really understand the local agency expectations about when it's acceptable to open a door and when it's not, what kinds of safety measures they need to attend to as they interface with potentially dangerous inmates. And it's possible that keys aren't promptly available, especially on morning watch, to provide necessary access. All right, here's another legal case, and this one is relevant to the topic of emergency response. This is Heflin versus Stewart County. In this case, the deputy went to the decedent's cell and saw a sheet tied to the cell bars. The deputy immediately went to the dispatcher's office, told the dispatcher to call the sheriff and the ambulance service, picked up the cell block keys, and returned to the open cell. When the deputy entered the cell, he observed the decedent hanging by the neck on the far side of the shower stall. The decedent's hands and feet were tied together, a rag was stuffed into his mouth, and his feet were touching the floor. With the body still hanging, the deputy checked for a pulse and signs of respiration, but he found none, even though the body was still warm. He also opened the decedent's eyes and found that the pupils were dilated. From these observations, the deputy concluded that the decedent was dead. While the deputy was still alone in the cell with the body hanging, a jail trustee arrived with a knife he had picked up in the kitchen. Rather than utilize the knife to cut the decedent down, the deputy ordered the trustee out of the area. The sheriff arrived shortly thereafter and directed the deputy to take pictures before he was cut down. At trial, the plaintiffs introduced evidence that the defendant maintained a policy of leaving victims as discovered, despite the medical procedures available to resuscitate victims. They ultimately prevailed, and a jury awarded damages to the decedent's family based on proof that the defendant acted with deliberate indifference after discovering the decedent's hanging. So in this case, it was determined that the jail didn't provide the kind of emergency response that is required in this case by the law. Okay. As far as best practice, one of the most important things is the idea of practice. Suicide prevention can't be taught to staff or effectively maintained by an institution unless it is regularly emphasized and staff have the skills and are trained frequently enough that those skills are sharp. So one of the most important things to do is to use mock drills to train staff. Mock drills are effective in testing the systems within an institution to determine whether they will function effectively in case of an emergency. Mock drills can help your institution answer questions like, will stretchers fit down our ranges? Do staff know where the cut-down tool is? Is the cut-down tool sharp enough to use? Do staff know where an AED is? Do they have personal protective gear with them? So it's important to amend your local training based on the results of your mock drills. When you realize that staff may not have a certain skill or know something, that's important to incorporate into annual training so that they then gain that skill.
It's also important during emergency response to make sure that you also train your staff in emotional preparedness for suicide attempts and death. Many staff members have not been exposed to death, dead bodies, etc., and so their response can also create breakdowns in the system so that the rest of the activities that they need to engage in aren't done. So it's also very important to make sure that your staff is trained in peak performance, high stress response, etc.
All right, that concludes our presentation for today. Dr. Brower and I would like to thank you for attending and for your attention. And although we're not going to cover them in this presentation, we want for you to know that there are additional slides that cover resources that might be relevant to your institution. That cover resources that can be found on the internet, resources for administrators, resources for clinicians, and training materials for staff. Thank you very much.
Thank you.